Hello, Assalamu alaikum, greeting to everyone. This is Dr. Sana. Uh, Today I will start the course of MRCPI Obs and Gynae Part 2 written in September 2024. So we have two Irish guidelines related to early pregnancy module. This is a table from the guideline which include some gestational ages and ultrasound features like at 4 to 2 weeks some experienced clinician can detect the intrauterine gestational sac which is around 2 to 3 millimeter. At 5 weeks what you see that gestation sac diameter is 5 millimeter. At 6 weeks it's around 10 millimeter. At 7 weeks you should see the fetal pole, and 8 weeks you should see the features like head size, limb buds, midgut herniation. At 9 weeks you see the choroid plexus, spine and limbs. At 10 weeks you can see these features like cardiac chambers, and at 11 weeks the gut is returning back to the abdomen. So this table is important for some ultrasound features. The next is about the pregnancy loss. So there are certain parameters like the size of gestational sac and the fetal cardiac activity presence or absence, which determine the pregnancy outcome. So if on TVS, specifically TVS, the gestation sac is less than 20 mm and there is no yolk sac or no fetal cardiac activity detected. At less than 8 mm, and this ultrasound prop should be put for 30 seconds at least to detect the fetal cardiac activity. Then on first ultrasound we will diagnose it. We can label it like unknown viability. So a repeat scan should be done in 7 to 10 days, and it is recommended before making a diagnosis. So till that point the diagnosis is pregnancy of unknown viability, and this is a recall question. Every year exam the question will come from this. On TVS, if fetal pole is more than 7 mm and gestation sac is more than 20 mm and there is no yolk sac and there is no fetal cardiac activity in the fetal pole more than 7 mm, then diagnosis of fetal demise can be made. So always if there is diagnosis of miscarriage is made, it should be confirmed by a rescan after 7 to 10 days. It is a must, and always in exam the question come like this. So for the second sonographer is opinion is only needed if there is a doubt in the diagnosis, or if there is a doubt in the competency of the sonographer who is doing. If the sonographer is competent and he has good number of clinical practice cases, so no need for second sonographer. Now this table is very important for the point of written and for the point of OSCE also, because the station will come for the counseling of patient with these features. In TVS is preferred for the diagnosis, but in some cases we cannot do TVS, so transabdominal can be done, but the parameters are different. In TVS, if embryo is more than 7 mm and no cardiac activity, then it is a miscarriage. And if gestation sac is more than 20 mm and there is no embryo or yolk sac, it is a miscarriage. Okay, but should be confirmed by a repeat scan. In transabdominal, the parameters are different. The embryo size should be more than 8 mm with no fetal cardiac activity, and gestation sac is more than 25 mm with no embryo or yolk sac, so it's a miscarriage. So 7 and 20 for TBS and 8 and 25 for TAS. Now there are some pitfalls with ultrasound in early pregnancy. So we cannot diagnose on the first scan because there are some discrepancies, like 50% of the women are unsure about the dates due to irregular cycles, maybe prolonged cycles, maybe they are lactating, maybe they just stop the OCPs and their cycles are not regular. So we should confirm the gestation from when their SPT become positive. And ultrasound also detect the multiple pregnancies and heterotopic pregnancy by visualizing all planes of uterus. There may be pseudosacs. Pseudosacs can be differentiated from the gestation sac because they are elliptical, and the gestation sacs are eccentric. They are mostly fundal in location, and pseudosac have no contents inside. So in the cases where the female have fibroids and uterus is distorted and enlarged, both TAS and TVS is recommended to see the gestational sac. Now the role of early pregnancy assessment unit. It's a very important part because in Ireland all maternity units should provide assessment by early pregnancy assessment unit. This is a specialized unit for early pregnancy problems. So after going through this assessment unit, 40% of the patient avoid surgery and less hospital stay. So it's cost effective also. This pregnancy unit should work at least 2 hours per day with ultrasound facilities by sonographer should be available. All patients with the positive pregnancy test must visit the early pregnancy assessment unit. These are the indications to go to the early pregnancy assessment unit. It's a recall question for OSCE and for written also. Any patient with the pregnancy test positive have vaginal bleeding or lower abdominal pain, any history of ectopic, any previous tubal surgery, any previous miscarriages, IUCD in situ, and she become pregnant, persistent bleeding after evacuation of retained product of conception, and as per indications of the local hospital protocols. So these are important. Now about early pregnancy assessment unit. So in early pregnancy assessment unit, there should be a facility of urine pregnancy test, beta HCG levels, and ultrasound, full blood count for the patient, and RH typing. Reporting should be done by a sonographer, and the couples with the diagnosis of miscarriage should be referred to support groups, and patient information leaflet, that is PIL, is provided to the couple. Options for management like conservative, medical, and surgical should be given to the patient. So this is an algorithm which can help you because it will contain the ultrasound scan, how you will approach the pregnancy of unknown location if you don't see anything, Then it can be intrauterine pregnancy, very early pregnancy, or it can be an ectopic, it can be a viable pregnancy, it can be resolved intrauterine pregnancy or non-viable. Then according to this we will approach the patient. Now our next part is the management of early pregnancy miscarriage. It is by RCPI, Irish Guideline, released in 2012. So historically, majority of the women underwent evacuation of retained product of conception surgically. But in the last 10 years, the management has changed, and women with the early pregnancy should be referred to early pregnancy assessment unit, as mentioned before. So if the pregnancy is viable, like the fetal cardiac activity is positive, so it will result in the live birth rate in 85 to 97% of the cases. So in the cases where there is a history of vaginal bleeding during pregnancy, there is a subchorionic hematoma or fetal bradycardia that is less than 80 beats per minute, like that is detected in early pregnancy, so further assessment is needed by ultrasound for these cases. Now there are some definitions, like pregnancy of uncertain viability. If gestation sac is equal to or less than 20 mm with no fetal pole, or fetal pole is equal to or less than 7 mm with no fetal cardiac activity. The same thing I discussed before. So we need to do a repeat TVS after 7 to 10 days. For the time being, up to the diagnosis is made, this pregnancy is referred pregnancy of uncertain viability, and it's a recall question. Then early pregnancy loss. If the gestation sac is 20 mm as mentioned before, or on transabdominal scan it is more than 25 mm, then or fetal pole is more than 7 mm on TVS and more than 8 mm on TAS, transabdominal scan, with no fetal cardiac activity, then we can label it for the time being as early pregnancy loss, but should be confirmed after 7 to 10 days by TBS. Incomplete miscarriage is when there is no intrauterine gestation sac with positive pregnancy test and thickened endometrium, which is equal to or more than 15 mm. Complete miscarriage after positive pregnancy test when endometrium thickness is less than 15 mm. So these definitions are important. Now coming to the management. Management all will be done by early pregnancy assessment unit. It will include the same things: history, examination, ultrasound, that is TBS is preferred, and in the cases, special cases where the gestation is less than 8 weeks, competency of sonographer is less, and there is suspect about the reliability of report, or the patient has history of irregular cycles, or woman request, because sometimes they will not accept the diagnosis, so repeat scan is indicated. And serial beta HCG facility should be available for suspicion of ectopic. And in Irish guideline there is an important of progesterone also. So they mentioned if the progesterone is less than 25, it will suggest a non-viable pregnancy. It's a high suspicion of non-viable pregnancy, and it's above, if it's above 60, it will suggest that strongly viable pregnancy. So there is a role of progesterone. Now management option. There will be 3 options for management: either conservative, medical, and surgical. Conservative management. So it is safe, effective, and acceptable to the woman. So follow-up scans will be required at 2 weeks. If incomplete miscarriage, expected management results in 79% of the clearance of pregnancy in 3 days. Overall success is 39%. Still 60% patient need either medical or surgical. And if there is a sign of infection or there is excessive bleeding, we may require intervention. So in conservative management, we let the patient wait, so the pregnancy products will expel by its own. Now coming to the next part, that is medical management. So in medical management, misoprostol is effective, acceptable. Success rate is 80 to 90%. But if there is a sign of infection or if there is a heavy bleeding, so it cannot be used. So the recommended dose of misoprostol is 600 microgram. 2 doses should be given 3 hours apart. It can be either given sublingual or it can be given per vaginum. So it's a recall question, the dosage of misoprostol. So after medical management, the rescan is advised after 2 weeks to see the either the products are expelled completely or no. Mostly outpatient management can be done in the case of medical management only in the condition if gestation sac is less than 50 mm. If IUCD is present and patient become pregnant with IUCD, it should be removed before misoprostol insertion. Next is the last step, that is surgical management. The indications are woman preference. If there is excessive bleeding, a patient is hemodynamically unstable, or there is a signs of infection, so surgical is preferred. Suction curettage is the method, and it should be a day procedure. Consider infection screening if indicated, like chlamydia, gonorrhea. If there is signs of infection or if there is a history indicating, then we can screen, but it's not mandatory for all patients. A routine antibiotic prophylaxis is not needed unless there is a sign of infection. If patient seems to be infected, then should be given IV antibiotics, and procedure can be delayed for 12 hours after the last dose of antibiotic. So there are risks associated with surgical management, like perforation, like surgical risk and trauma, infection, and anesthesia complications. For surgical management, written consent is needed, and perforation risk is around 1%. So now coming to the post-op care. The product of conception in all cases of miscarriage should be sent for histopathology examination in surgical cases. RH and TD prophylaxis should be needed in non-sensitized women. What are the cases where NTD prophylaxis is needed? It's a recall question also. In all cases of ectopic pregnancy, in miscarriages above 12 weeks, and if surgical management of miscarriage is done, then NTD should be given to all non-sensitized RH negative women. NTD in all cases of threatened miscarriage is needed if it is associated with the pain, significant pain, heavy repeated bleeding. No NTD is required in complete miscarriage if it is less than 12 weeks of gestation. And at the last, miscarriage is very traumatizing for women and couple, so psychological support is given to the couple and should be referred to the support groups.